complete colonoscopy in February this year. It's a 70% circumferential mass as picture. It's a 5 to 10 centimeter from the inner verge, and the biopsy show polydifferentiation adenocarcinoma with mucinous and signet ring cell feature with proficient MR. And we send a workup for the CAT scan, chest and whole abdomen, MRI, and CA show 12.3, and underlying indices is diabetes, type 2 hypertension, and dyslipidemia. And this is a CAT scan of the whole abdomen, show no liver metastases, no distant metastases at this point. And here is a thickening wall of the rectum, and this again. Okay. Oh, so sorry, it is same. Here is our CT chest, show no evidence of the lung metastases. So here is our MRI. It's quite fast. I will show a little bit slower. Here's a tumor here near the bladder. For the sagittal view, for this patient, he got like a metallic artifact from the prior surgical clip, so it's maybe not clear at the tumor. And here there's a tumor. We show this. Is a tumor appear involve the peritoneal at the lateral aspect near the bladder, and this one may be better. Here is a tumor. With a in this cut, yeah, you may see the EMVI positive at 4 to 5 o'clock, and lymph node, there is a identified 5 lymph node at the mesorectal, superior rectal, and inferior mesenteric artery, and no extra mesorectal node involved. Okay. And, oh, so sorry, I have to push it back. Oh, can it go back? And what should we do in the next step at this point? And
sorry,
so,
because we rush off the time, therefore we're gonna
yeah.
go forward to the next step. Because this is a locally advanced rectal cancer with the EMVI positive and also the threatened margin. Therefore, we decided to do the long course CCRT for this patient. And he received the
long course.
Yeah, 50.4 grade
Yep.
radiation, and also the C-log, the capecitabine oral, along with the CCRT. And after that, he received one more FOLFOX cycle and performed the MRI.
And the MRI show that no significant decrease of the tumor size and have a little bit unclear and the anterior of the tumor. So what should we do
Yeah.
for the next step?
Can I ask Professor Art, because at this time, the problem is we already received the long course CCRT, and actually we plan for the consolidation chemotherapy. However, this case is a mucinous adenocarcinoma, and we know that MMR is proficient, and we know that this gonna be have a little bit poor response from the CCRT. Therefore, we a little bit fear that should we go forward for the consolidation chemotherapy, or we decided to do the extensive surgery at this point, like a pelvic extension or something like that. What do you think for this patient?
Oh.
Right. Of course, this would be a difficult case to decide of which treatment would be the most effective treatment plan for this patient. So I would agree that this patient is not only the locally advanced mid-rectal cancers, mid to low rectal cancers, but also has the positivities of circumferential threatening, and then that which is reflecting the local recurrences, and then the EMVI positivity, which is reflecting the systemic spreading of recurrences as well. And plus the limitation of tumor biology that might be resistant to conventional systemic treatments. So as a surgeon, in my opinion, I'm not sure if other surgeons would be agreeing with me. I think if the patient is resectable, even though it would be quite an invasive procedures, but doable, and if we review carefully all the images studies, including the pelvic MRI, I think in my opinion, is doable for the complete resection. The good thing for this case is that the tumor locations is not close to or nearby the sphincters. That's a good thing, so that we don't need to worry about that too much. So in my opinion, even in this case, we would discuss these potential plans among the multidisciplinary specialists of all the disciplines. And if I would be in that board as well, I would be offering a radical resection upfront for this case. Thank you.
We're gonna finish with all of our surgeon, and you go for
Okay.
the oncologist and
Okay.
what do you think?
What is the patient symptom right now?
He's better for defecation.
The bowel motion is okay, right?
Yes, yes.
All right. The signet ring cells, the outcome always unpredictable, and we have the same scenario like this. When we have the complete course of the radiation, but the tumor still there, we like to see the downsizings of the tumor so we can approach to it safer, right? But it's like this. Perhaps sometime we have more aggressive finding after the radiation in some case. I strongly agree with you that the surgery may be the only option, because it's very difficult to predict the response from some other neoadjuvant treatment. But I'm not sure whether you try to see if the patient may get some benefit from target therapy. That may be another way to do. So I like to bring this to the tumor board and see whether we can add on some benefit. If I can, I like to see smaller size, then I can get R0 resection. Otherwise, sometimes we might be forced to do supralevator exenteration. Because if we leave the positive margin, the patient will come back with a very difficult scenario.
Okay. The next, Professor Weiser, what do you suggest?
Yeah, I agree with both opinions. This is the Janus trial that's looking at the triplet after chemoradiation. We don't know the results. I would be inclined maybe to start chemotherapy and keep a very close eye. Any sort of progression was going to make surgery harder, but we may get a response. And we have seen patients that don't respond to chemoradiation or don't appear to, but can get a response from chemotherapy, a doublet or a triplet. And mucin is always difficult to assess response because it is very slow to clear. So I don't think there's a right or wrong answer. If you give chemotherapy and you progress, then you made the wrong decision. And if you do surgery and have a positive margin, you made the wrong decision. So I think we're stuck either way.
Yes, because for me as a surgeon, I saw this patient, and this is not a regular TME because we cannot get this tumor off with a clear margin. Therefore, we need to have like at least a prostatectomy. But for myself, I see MRI. I think exenteration is the best option for the surgery. However, on the other hand, the patient may have a morbidity from our surgery, and can we give them a further response by drugs or radiation or something like that? Therefore,
Actually, this is my own patient. So actually, his symptoms improved after chemoradiation, but the size is there. Unfortunately, this patient got clips on the rectum, so that's why we cannot evaluate the primary disease as well. But he is getting better during the treatment course, not even like right now. In my opinion, I agree with Professor Weiser that if we wait longer by giving more systemic treatment, because if you look at the data I show for the German trial, when they see at the first beginning, they see the complete response only like almost 20%. But if we wait longer, but not wait, just wait, they give more systemic treatment. And that went until 3 months, which is the regular time for our TNT. They got more response to higher, like 30-something%. So it might not be that worse to get more systemic chemotherapy.
So I'm not sure if that information, like that piece of information or evidence is applicable to this particular mucinous carcinoma.
Yeah. So for me, how long from the last radiation to perform this imaging?
It's 8 weeks. It's the last radiation complete on the May 2nd, and this MRI is July 8th. It's about 8 weeks, 2 months.
So obviously, in the medical oncologist point of view, given the chemotherapy first upfront, we can test the tumor biology. This is the best way to do. So in this case, it seems to be the tumor did not respond to the treatment. However, I think for the next step to do in this case, actually, if the response will do the scan at maybe 3 months after the finish of the radiation, and you still hear this effect, I would prefer to do the surgery first. But if it's just only for the 2 months, I will continue the chemotherapy and then reevaluate shortly after maybe 3 months, whatever, to see the effect of longer follow-up of the radiation finish and adding chemotherapy. However, the question is, do I offer for more systemic treatment before the surgery. So far, we have no data that adding the third drugs or adding targeted treatment will improve the outcome. However, in the next case, for me, if I see this kind of patients, I will use like a PRODIGE 23 cases, which is the introduction of FOLFIRINOX first for maybe 3 months to see the effect. Because of if you already know that adding more chemotherapy in the advanced stage have higher objective response when compared with just only doublet treatment. This may be another option in the next patient. Just start with this third triplet followed by long course CCRT. But for this case, for me, if just 2 months, I will continue the CEMIT for 1 more month and reevaluate the MRI. And if the tumor still be there, I will refer to the surgery.
At this point, if we use a triplet, what do you think?
Because of this is after concurrent chemoradiation already, we have no data for adding the third drug in the consolidations. You can try, but I have no data to support the use of the third drugs.
Yes.
I'm not sure if we would have the details on learning more of the tumor biology, particularly in this case, in order to add on targeted treatment or biologic treatment before surgery.
Actually, you can trial. We have that, but anyway, we have no data to support this technique. But anyway, if the tumor still be there, normally we will not change to another treatment regimen. But anyway, if you test for the molecular testing, as it turned out to be the wild type tumor, so we went wild type last. You may add the anti-EGFR to get more response rate, because we already know that adding anti-EGFR with the chemotherapy get the highest response in the tumors. We can try actually, but we have to data.
Yes, because after the CCRT, MRI, because the MMR and also the molecular testing is not routinely used in Thailand. Therefore, we need to discuss to the patient case by case, because they need to pay by their pocket. Therefore, in this situation, after I saw the MRI, I discussed with the patient to recommend to further investigation, because I know that this tumor is not like a regular tumor that we found everyday practice. Therefore, but now they still consider about the test price and also the drug. Because if we test and they cannot afford the drug, maybe it's not a benefit to test it. Yeah, this is
Dr. Weiser, in a memory salon, do the oncologists add the third drugs or targeted therapy in these particular cases?
So I do think this would have been a very good case to start with the triplet, start with chemotherapy, because it seems with the poor differentiation, MMR proficient in multiple lymph nodes, there's a significant risk of distant spread. But we don't know that. So I think both approaches are fine. No, in our tumor board, we would be split. Some of the oncologists would say there is no data, we're not going to use it, and others would try because it is an odd case, and the response has been so limited so far. Yeah.
And I think another thing that we have to concern about is that even though if the patient is lucky enough that would be good responder to whatever systemic treatment or treatments, we surgeon would be going to do the surgery based on the original imagings anyways, because as Dr. Weissner presented just now, that the pattern of responses of neoadjuvant treatment would be different, so we'll never know, right?
I like to address something. We are trying to make the tumor smaller, become resectable. But actually, if you look at the margin in this case, I think the lateral margin is very difficult, right? You cannot see the clear CIM in this case. So I still I think this is very difficult to get to the plane. I'm not sure after the treatment, adjuvant treatment is going to be better than this. I just think about your wording that you said we have to be very close monitoring in this. What is the idea of how close you do, how many cycle of the treatment you're gonna try, and what is the cut point that we should move forward to the radical surgery? In this case, if the patient has no question about the urine function, the patient will wear just only one bag, right? Because we can preserve the anal canal in this case. The ileal conduit, just ileal conduit may be okay. And then we can go for the supralevator centration without a doubt, because we can go to the clear margin laterally. But if it can be smaller, we can try to do a bladder preservation surgery. Also, I need your...
Yeah, I don't think we know for sure, but if at this point we have to do an exoneration, then even more reason to give the chemotherapy, because maybe, as you said, we'll get a response and we could do something less. Plus, we're going to treat the distant sites, which they seem at very high risk for distant metastases. So if exoneration is necessary now, I think there would be more reason to give chemotherapy, and I would probably reevaluate in 6 weeks, maybe 2 months. It's hard to say, but I wouldn't necessarily wait a full 3 months. If the patient has symptoms, you can follow the symptoms, but it sounds like they've gotten better already with the radiation, which means there must have been some sort of response if they're feeling better.
Yes, thank you very much for the panel, because this is quite a difficult case to make a decision. Actually, he's one of a relative of our urologist. Therefore, it's much really difficult to discuss about the exoneration as well. Yeah, thank you very much for your opinion, and I will come back, go back to discuss with them. Yeah, thank you very much. And sorry for the delay of our session, and we're gonna have a lunch that already prepared outside, and we will return to this room at 1 p.m. Thank you so much.